I would say sometimes, at least for me, I feel like the Sorcerer's Apprentice from the old Disney movie where it just gets faster and faster and we're just trying to keep up.
From Research to Real Life, a podcast brought to you by the Clinical and Translational Science Collaborative of Northern Ohio.
Welcome to another episode of From Research to Real Life. I am your host, Lora Parent. And today's episode is all about shifts in scientific landscape, shifts in research priorities, public trust in science, how everything has changed and shifted over time. So I'm excited today to really talk about how things like telehealth, technology, integrative approaches have now continued to emerge, reshape, and kind of restructure maybe how research is being conducted, how we are receiving research, and translating that into practice today. So I would like to start by welcoming our guests. So good afternoon. Our first guest today is Dr. Martha Sajatovic. She is a professor of psychiatry and neurology at Case Western Reserve University in the School of Medicine. She's a clinician, an educator, and internationally recognized researcher focused on psychiatric neurological care for older adults. She leads the first global consortium devoted to bipolar disorder and aging and has authored more than 500 peer-reviewed publications. So welcome, Martha.
Thank you. I'm happy to be here.
Yes, wonderful. Also joining us today is Dr. Sam Rogers-Melnick from Connor Whole Health at University Hospitals. So welcome, Sam. His research spans integrative health, music therapy, mixed method trials, electronic health record research, and his work really focuses on implementing whole health assessment tools directly into clinical systems. So welcome to you, Sam.
Glad to be here.
Yes, we are very happy to have you both, and I'm excited to kick off the conversation. So let's kind of start with a really big picture, and then we can narrow it down throughout the conversation. But let's think about science as a vacuum. It's shaped by technology, funding, public trust, societal needs. So Martha, if I can start with you, what has maybe been the most significant shift in scientific inquiry, public perception, since maybe you began your career? It's a pretty meaty question, but I'd love to hear your thoughts.
Yeah, so for me, it's been almost 4 decades, just seeing many, many things change. I would really say what you mentioned earlier about technology, just dramatically changing the way we do science, what we can do, how we can do, has just been incredible. And it has led to differences in how we approach answering research questions. So, just even simple examples. You had mentioned in the intro that I am involved in a global consortium, which has currently the world's biggest database on older age bipolar disorder. So we have research samples from all over the world, probably about 6,000 cases at this point, but this never would have been possible earlier in my career. So we have people or sites that send us data securely, electronically. We can keep that data in one place. I never would have imagined this when I first started my career, but a Zoom meeting with 45 investigators around the world talking about our data, planning our analyses. So we can use our time very efficiently, and we can involve people that I think perhaps wouldn't have been involved before, just because of that reach and the efficiency that we had.
So Sam, I want to shift to you now and talk a little bit about how maybe some of the things you're involved with in your research are maybe changing the landscape a little bit, and you're coming in with some cool technology and using EHR to help your research and maybe think of some new ideas in this research community. So tell me a little bit about your background, your experience, and some of the things you're kind of dealing with in these shifting landscapes.
Yeah, well, I had no intention of getting into research when I started my career. I came to University Hospitals as a music therapy intern in 2012. My internship project was doing group drumming for adults with sickle cell disease who were admitted with pain crises on the medical oncology unit. And we noticed during those sessions, patients, they'd be engaged in drumming for an hour. They reported it really helped their pain. We are also able to bring nurses and staff, and sometimes that, when you're creating music with other people, it can relieve some tension. It can open up some communication. It can also bring people together to support each other, sort of like you're seeing in the epilepsy support groups. And at that time, there was no research in sickle cell disease for music therapy. And my passion for working with that population and also the need to sustain my position financially led to a first Coolest Foundation grant to do a randomized controlled trial comparing music therapy to listening to music to control, to doing songwriting interventions, to promote and address the transition from pediatric to adult care. That led to another series of funding from the Coolest Foundation looking at, can we go beyond chronic pain to give people resources with music to address the pain that they feel every day? And at that time, I was really skeptical of telehealth because a lot of the music therapy interventions that I practice and we use in our studies they're interactive. We're writing songs together, we're drumming together, we're keyboard improvising together, we're breathing together with the music. And like, if there's any lag time, like it's rough. And we were fortunate when COVID hit, our directors, Seneca Block, and the whole expressive therapies team, we pivoted virtual and we did everything we were good. You know, I worked on the stem cell transplant unit. I was calling patients and singing to them over the phone. We were doing like FaceTime rap sessions. I was trying to get the lag time down. And eventually we figured out, well, there are certain plugins where I do a lot of electronic music production. So we bring in beats and nature sounds and I add the reverb to my voice and the guitar effect and I can create it in the laptop and then send that straight through Zoom. And so now the participant can hear the music therapy intervention as it's being created. If we use some web portals, we can do keyboard improvisation back and forth. We're doing a multi-site R01 now, supported by the NIH to look at the multi-site feasibility of music therapy for patients with sickle cell disease. We have an in-person arm, and then we have a virtual arm where that first session is still in person because I think you have to build that trust, but the next 5 are virtual. If you live in a rural South Carolina or you live in a place with poor broadband access, we'll give you an iPad with LTE. We'll do music therapy that way. I think that's opening up a lot of access, and certainly if we want to scale these music therapy interventions for people with chronic illness, that can open up a lot. So I think telehealth is helping us. I think on the electronic health records front, there are interventions. So I think there's a lot of promise to what electronic health records can do to make sure we're capturing what matters and to target our interventions appropriately.
Yeah. So Martha, how maybe have you seen this snowball effect translate into your areas?
Yeah, so let me tell you a little bit building on the epilepsy theme. So I do work in many different neurological and psychiatric conditions, but I've really done quite a bit with epilepsy. Most of it's supported by the CDC, Centers for Disease Control and Prevention. So we have a project that we're running in now. This is our third year program. It's called the Expand Project. And the idea would be to take our curriculum that we've tested. So we did an efficacy trial, and then we did an effectiveness trial that was more kind of real world. And now we are doing what I think of as science to service, where we take the program that we know works and we know we can expect really good outcomes when we do it in a research setting. What's happened if we scale it up into the real world? So this is a project being done at the University of Iowa, University of Cincinnati. I am the program developer here at CASE in Cleveland at University Hospitals. And we have clinicians who are using EPIC, both in Iowa and in Cincinnati, Iowa City and Cincinnati. We've worked with their EPIC team to filter and flag people with epilepsy who have certain characteristics. They're rural, they've had a seizure, different things that we can pick up relatively easily from the health record. Then when that patient goes to see their clinician, there's a pop-up that comes into the health record while that clinician is filling out their form and charting that says, your patient will be a candidate for the SMART program, which is our epilepsy self-management program. The clinician has the option to talk with their patient at that time, Maybe they've got something else going on that's an acute medical issue, and they can say, not now, but let's come back to it later. Or if they feel it's appropriate, they will speak with their patient. If the patient says, yeah, I might be interested in doing that, then they send an EPIC prompt to the administrative team, who then follows up and can get them into our remotely delivered SMART program. So I think that's an example where, we use that health record in an interactive way to get the people that would potentially benefit from our programming to have the programming. The part of it's the performance evaluation is we have certain metrics, seizures, your quality of life, your depression level, and we now have and are amassing a critical volume of data to show that we are seeing the same good responses in this real world setting, non-research, that we saw in our research settings. So amazing how you can use the health record, not just to document stuff, but to interact with your care team.
So it sounds great conceptually. And I'm curious, though, how do you get the buy-in then from the clinician and also from the patient end too? I mean, it almost seems like you're both in the middle here and you've got really great tools at your hands. How then can we act on that? How do we get the buy-in that we need, maybe financially, maybe from the clinicians themselves, to be delivered appropriately and effectively?
Well, I think at Connor Whole Health, we have very skilled practitioners in music therapy, acupuncture, massage therapy, lifestyle medicine, chiropractic, modalities that are not well covered by insurance, sometimes not covered at all. We practice areas that have an emerging evidence base with randomized control trials and different things, but some of the real world clinical effectiveness evidence is not where we'd like it to be. We are constantly having to advocate for ourselves and the importance of what we do. And I see my job as I'm trying to make it as easy as possible to capture the impact that I know that you're having. We see thousands of people with music therapy every year, and we have profound effects on their pain, their stress, their anxiety. We're brought in to teach people new ways of coping. We can tell really profound stories with the songs that we create, but that can also boil down to really important symptom data. And I did a dissertation about, what music therapy interventions are working better, and do we have an impact on length of stay? In outpatient Connor Whole Health, we see thousands of people with chronic pain, and we should ask about that to see if we're making an impact. And there's also things coming, like the Centers for Medicare and Medicaid Services in certain populations, like hip replacement, knee replacement, they're going to need that patient-reported outcome for reimbursement. That's also happening in oncology care models. And so that can be an incentive structure as well. But I operate with, we're trying to capture the impact that we know you're having. And then down the road, what could work best, right? Can we capture these outcomes early so that we can target interventions the best that we can? If we can get it at Connor Whole Health, and then the Chronic Pain Center could get those outcomes with our whole health assessment, the Department of Psychiatry. We could also look at long-term, which care models are working best to improve chronic pain, to reduce stress, to improve health-related quality of life, things like that.
Yeah. And I would say as a researcher, it is our responsibility to try to get information on outcomes that are important to everybody who's a stakeholder, right? So quality of life outcomes, if I tell a person with epilepsy, if you do our SMART program, your depression is going to get better, your quality of life is going to get better, you're going to be more competent at managing your whole health. So I can tell them, here's the data. And then for the administrators and for the insurers, we designed our study so that we looked at important parts of health resource use. So instead of just saying, how many outpatient visits did you have and how many hospital visits did you have, I think that way of looking at it doesn't necessarily translate meaningfully to payers. So instead, what we did with our program is we looked at complications. So let's say you have epilepsy and you're having a bunch of seizures and you can't go anywhere and you're stuck in your house. You don't go see the dentist. You don't go see your primary care doctor. You don't take care of preventative care that's going to help you from having problems. So maybe once we get you on the road with self-management, now you're taking care of all that backlog stuff. So if I just count visits, I'm not counting the right thing because you're using visits for the right reason. Instead, we looked at complications. So we looked at emergency room visits, hospitalizations, seizures, self-harm attempts, all of the things that when they happen, I think we could all agree that this is bad. Nobody wants to go to the emergency room. They're not fun places to hang around. And we can show that we can reduce these metrics, these negative health events. So then we can go to payers or we can go to hospitals and say, look, this is worth it to you because you can avoid what we call negative health events, these complications. So I think it's really having attention to outcomes that everybody has a stake in.
So how do you both see technology serving as a bridge between the traditional clinical research and maybe newer, more holistic models of care and patient experience?
Well, I think it can provide an opportunity to take a lot of friction out of the system. If we have wearables now that are capturing your steps and heart rate and various other things already, and that can talk to a common record. If we're asking you important questions that matter to the patient and also matter to all of the clinicians, those should be integrated so I can graph my quality of life just like I can graph my cholesterol. Things that make it a more seamless experience, which I think was the intent of a lot of this technology we have embarked on. And then I think it can also help with scale. Like we recently ran a study called Music Pups, Music Therapy for patients undergoing pancreatic surgery. And in that context, unfortunately, there's only usually like one music therapist per hospital. It's hard to see people every day when we have a lot of people on our list. So let's say you're just recovering from this intensive Whipple pancreatic surgery. I can do a live intervention with you. I can record that intervention in real time in a high quality studio and at the same time, and then give that intervention for you to listen to and monitor outcomes like that. We're trying to do that in the context of COPD and heart failure and chronic pain. Can we use these things that scale these interventions and also target them to the people that need them most?
And I would say it really can add tremendous value. So just to, at risk of having one theme here, but to just go back to our epilepsy example and our epilepsy self-management curriculum. So in standard settings, an epilepsy specialist will ask their patient, have you had any seizures? And so then the focus tends to be on, if you've had seizures and how many and what do they look like and what medications we use and so on. And that's important. That's what they're there for. But now with additional behavioral approaches that support the whole person and not just their seizures, now all of a sudden you're talking about mental health comorbidity and depression severity, and we can encourage depression screening, and we can look at self-management competencies and where you're doing well or where you're having some challenges or where you can get some additional supports. And that can really help the epilepsy care clinician as well. So it's not just about, do I need to change the medicine? I may need to do that, but is the person having depression or missing their medications because of some other things going on in their lives? So it can really be a huge bonus to treatment planning when we think that way, more holistically about the person with the chronic health condition rather than just what's going on with your seizures right now.
Yeah. So let's think about the future. Flying cars, AI, you wake up in the morning, they have your cup of coffee ready for you. Here's your report, Dr. Melnick, for the day. Where do we see, or where do we hope our research has taken us in that time, in the next 10 to 20 years? What do you both hope either maybe is going to change or maybe has changed for the better with the work that you're doing now, or that you can see maybe transpiring down the road?
Well, I think we talked about electronic health records, and now electronic health records have partnered or made these exclusive databases to pool all the de-identified data, whether it's Epic Cosmos or Trinetics. And there's a fundamental challenge I have with those platforms is that they don't know when integrative health and medicine happened. They know when people are diagnosed with things. They know when things are billed. So like chiropractic research can be really great. My colleague Robert Traeger is a prolific chiropractic researcher because there's all these patients with billed chiropractic or not. But if you look for music therapy, won't find it. You look for massage therapy, won't find it. You look for a lot of group medical visits or lifestyle medicine or non-billed acupuncture or yoga or these things that are happening in health systems around the country. They're documented in notes and flow sheets and the data is in the electronic health record. They just don't know that it happened. Mm-hmm. So if you want to do a nice observational study with a PICO question and your integrative health and medicine intervention is the intervention of interest, you can't find it. So I'd like to solve that problem. And I think that can also help with greater billing and reimbursement. And also, you need the exposure of interest in those records, but you also need the immediate outcome of interest. Yes, we can look at ED visits and we can look at billing and subsequent utilization where you're diagnosed with something, but I care about immediate and long-term changes in quality of life. And if you're a health system that's collecting that already, we should put those in the research databases as well. I think things being more integrated to look at those things. So when you're trying to do like these observational studies with propensity score matching, so you're matching these people that got music therapy to these people that didn't on hundreds of different covariates because you couldn't run a randomized controlled trial. Like you want that to be in place. And then I think everything is probably going to have a cost effectiveness component.
I would agree that billing, cost effectiveness is going to be important. There are ways to pay for peer educators or community health workers, but they're not great models and they're not widely used because there is problems in getting reimbursement for that. So I think that's a concern. And then I think it's really important not to lose the value of that human interaction. So we recently had completed a project for patients with schizophrenia where we delivered a adherence promotion intervention. So we took it from an in-person program to a virtually delivered program, remotely delivered program. That was good. Schizophrenia is highly stigmatized. People are, they're isolated, they're marginalized. It brought them together. They're interacting. We did get some comments that it would be nice to meet in person. That might be hard if you're, 1,000 miles apart. But then I had a request from our sponsor for this program to say, can we just turn this into an online program? And can people just do this on their own? Can you create some enduring materials? And we surveyed our folks through some mixed methods and found that people with schizophrenia, for the most part, are not always jazzed about that, right? They're already isolated and they're stigmatized, and just giving them something to do alone on their computer is not going to solve some of those issues. So I think finding the right mix of using technology when it makes things more efficient, but you don't want to throw the baby out with the bathwater and lose what's really the secret sauce or the essence of that interaction.
Let's talk about maybe the negative stigma associated with technology and maybe how that has affected some patients and maybe their willingness to either come to a clinical trial or research information online themselves, right? Trying to be Dr. Google themselves. How do you see that, or maybe the downside of technology? How has that maybe affected some of what you're doing or what you're trying to do with your research and your work today?
Well, I think technology has become a burden in a lot of ways. We are over notified. I mean, there was a time before I got into research where if you wanted a patient-reported outcome, you mailed it to somebody. And they checked their mailbox and they filled it out and they mailed it back. And then we did email surveys. Well, I got in my email and I wasn't spammed too much. So I get the email, think I fill it out and send it back. And then everybody got spammed. And then we're like, let's text people. So Twilio, let's text people. That'll work. And now everyone is spam texted all the time. Yeah. And it's really hard because it's like, no, it's me. I'm from the study. So like you enroll somebody, you're like, put the study number in your phone. Like it's the major cord study. Like you're getting it. And I think that's a challenge. I think people are very wary. Like, what are you collecting this data for? Why do you need to know that? Right. And that's where it comes back to like even our whimsy study that we're doing right now is a whole health assessment in a large health system. If we ask patients questions about their health, we need to talk about it. We need to convey that it's important, that we value it, that it's important that we know what their goals are, and then we're tracking that over time. So it's not just like, well, I just filled out this 100-question questionnaire, and then is it just going into the ether so you can track something? Yeah. I think that's the tension. I think payers and technology companies will want to say that their technology is the complete answer. And I'm really skeptical that it is. I'm a music therapy researcher. I'm not a music medicine researcher. All of my research involves around a board-certified music therapist who develops a therapeutic relationship with a patient and helps motivate the patient in achieving their goals. That's what I'm interested in. That's what I know works. Mm-hmm. There are other models where it's like, I got this sweet Spotify algorithm that'll get you the perfect playlist. I'm sure that can be helpful, but a lot of the people that we see, they don't quite have the self-management skills to use that by themselves. I imagine it's a similar phenomenon with patients with schizophrenia or patients with epilepsy. I think technology can augment, but I think, especially now with AI, I don't think people really want that. They want to trust their doctor. They want to trust the people that they're coming and seeing. Like, people say AI can revolutionize cancer care. It's like, well, if I was diagnosed with cancer, I wouldn't want to talk to an AI chatbot. I want to talk to a real human being that's advising me on my condition. And I think we have to navigate that. It's becoming harder to collect data now because everyone is so overburdened with notifications and data collection tools.
Did you have something?
Yeah, I would also say I think it's really important that we continue to stress our credibility, the institutions that we work with, the fact that we have institutional review boards, that we have research oversight. And people with health conditions may not necessarily know the difference between market research or somebody trying to sell them something versus doing a NIH or other funded, clinical trial where we've got appropriate external oversight. It is quite burdensome to go through all of the regulatory stuff, but it's essential, and it helps preserve that kind of credibility that we have. So we can go to people with epilepsy or schizophrenia or stroke and say, this has gone through peer review. Scientists in the US who are tops in their field have endorsed this. We've got funding from this entity. We are going to publish the results in a peer-reviewed scientific journal. Your identity is not going to be made public at all, but you will contribute to advancing science and advancing clinical care. And I think that really helps. That's so important to communicate that to our research participants and to our patients.
Yeah. So I want to start with you, Martha, as we kind of wrap up our discussion today. Tell me what you're most excited for, what you're looking forward to in the next 5 years.
That's a hard one. there's a, as you know, plenty of uncertainty in the research field, but I would say that there's a few things I think we can count on. I think technology is going to continue to evolve and advance. So I think we have to consider it in our interventions. We talked a little bit about team science. I think team science is going to continue to advance. I think we do have to be able to continue to look at different perspectives and different subpopulations. So, I would have to say one of the criticisms I would have for many of the findings that we have from our randomized clinical trials is that it tends to enroll a very specific kind of narrow segment of the population, sort of one size fits all. And I'm hopeful that with amplification and greater reach, that hopefully technology and other scientific methods can teach us that we can be more nimble in developing approaches that would be customized to an individual or apply to their specific situation.
Sam?
Well, even my journey to becoming a researcher, when I started out, I was like, I'm a music therapist here. I also do some research, but I'm primarily a music therapist. And then it was like 2020, 2021, it was like, actually, I'm going to be a researcher. I'm going to get a PhD, which I just got. And I'm going through this. And when I started, I was like, I had no understanding or awareness of how the NIH operates or any federal mechanism. I didn't know an F award from a K award or an R award. But as I started to become more aware and get mentorship from people at university hospitals and CASE, I really came into this great moment where just like in fall of 2022, the NIH was really interested in music and health research, pain research, and sickle cell disease research. And I was like, well, that's really great for me and all the endeavors that we're doing. And we got 3 NIH awards. With all the changes, there is still a published intention to still advance music and health research to address, upstream lifestyle, diet, exercise, nutrition factors that affect people's health, to use real world data in a responsible way. And I, as now recent PhD graduate in this environment, and Dr. Sajatovic is very good in navigating all these different things. It's navigating, okay, if this aligns with a federal funding mechanism, we go for that, but we have to pivot to foundation and philanthropic funding mechanisms to make sure that we're still doing very good science and measuring what matters. My focus is still going to be on that right side of the translational spectrum. How do we take things that we know work from randomized controlled trials and look at their real world effectiveness through electronic health records, and then implement them throughout health systems, whether that's music therapy, patient-reported outcomes, or what we're really focusing on right now with Dr. Arts and Conwell Health is health coaching, and what that can do and how that can be cost-effective for addressing people's hemoglobin A1C, their health-related quality of life, and engaging in health behaviors. So I think as we move toward the future, let's try to make sure that we're capturing the things that matter. Let's know when health coaching happens. Let's know when music therapy happens. Let's know when acupuncture happens. And let's measure the things that we say that we're trying to address. We want to make a difference in people's health-related quality of life, their chronic pain. Let's capture those things and work together to see if we're making a difference on those with our interventions.
Yeah. Well, we are very happy to have you both here sharing your knowledge, your experience, your hopes and wishes for the future. And the CTSC is here to help you still both on your career journeys, but also our viewers as well. So if you are interested in learning more about resources that support innovative translational research, so that kind of T3, T4 area across research stages, feel free to contact the CTSC. Also, you're both integrated into the CTSC as well. So
you can request a consult with me now.
So if you want to talk more about integrative health, you would contact Sam. If you want to talk more about maybe CBPR or any community engaged research, right? We're contacting Martha. So
through a Spark request.
Yeah, very familiar with the Spark system. So this discussion really just was really insightful. It really takes a network of people, and it takes us having just discussions about what's happening, what's changing, and what works and maybe what doesn't work as we kind of traverse the unknown, right? There's going to be a lot that we don't know coming down the road, but that we all, with our shared resources and, kind of positive attitudes, we can get through this all together, and we will be here to kind of experience what's to come in real time. So I'm looking forward to that. I'm excited to see where your journey goes in your research,
Find out.
Kicking that off, and Martha continuing to see just what grows and what's continuing to be successful in your research journey as well. So thank you both for your time, and we look forward to seeing you on another episode of From Research to Real Life.
From Research to Real Life is brought to you by the CTSC of Northern Ohio. The views, recommendations, and opinions expressed in this podcast are those of the presenters and not necessarily of CTSC and its partners.